So the posterolateral impingement is just something I've started to see in some of the cases, and it was a clear anatomy or pathology in the beginning. So I started to look at it. I started seeing this different pathology in the back. We always think of hip impingement more anterior. We're flexing, we're impinging anterior, and truly most of the pathology is anterolateral, usually from 12 o'clock to 3 o'clock. This is what we usually see. And our repair and cam excision, labral repair, is in the anterior part. So this is a slightly different things starting to look at. So the aim is really to describe the posterolateral impingement, look at the pathology and treatment options. You all know the different types of FAI, and the most common is the mixed type. We have the cam, the pincer, and the most common is the mix. So most of the patients have a combination of both. But this is anterolateral impingement. So we're looking at the hip is impinging anterior. You get from the cam, you get the labral tear, the delamination. And if it's very strong impingement, you get the small lesions on the back, which is the contrecoup lesions. Now, this posterolateral impingement is actually the reverse. I think it's happening when the patient is extending. It happens in abduction and flexion. So when we're testing range of motion, it's really in abduction and flexion, and that causes pain in the hip. And I think it also limits, especially in the females, it might affect this position in sexual activity, and they have a lot of pain. And I see it more, I think there's over coverage of the posterior part. The acetabulum is over covered, and it impinges on the back, and it may lead to a reverse contrecoup lesion. Now, this posterolateral impingement we've seen in cases separately, and we've seen it in combination with actually also anterior impingement and cam. So you find it in both conditions. So what does it have? It has acetabular overcoverage. It's too much acetabulum on the back. That's why the hip is impinging when it's causing abduction in flexion position. It impinges on the back side. It may lever anteriorly, causing the reverse contrecoup lesion. And you will find also labral tear, anterior labral tears with that. So it's not only you're looking at the back problem, but it actually causes anterior labral tearing, whether you have the cam in the front or not. And you may have, as I said, associated anterior impingement also. So for the radiology, you will see the acetabular rim is exaggerated, and I'll show you now, lateral to the center of the head. You may find the classic cam anterior, so it may be associated. And when you do an MRA, you'll find also your anterior labral tear. So although it's a posterior impingement, it's not that we commonly diagnose that from the posterior labral tear, but it's actually the anterior labral tear which is the indication that you go inside. And this is a classic example. This patient, she has bilateral over coverage, and if you see on both sides, she has too much bone on the lateral side. And I don't want you to confuse that with the center edge angle. Some people may look at it and describe that as a high CE angle, but it's not. It's not a lateral central edge angle that's exaggerated, but it's the posterolateral acetabular rim. This is the extra bone I'm talking about. It's present in both sides. So this is a wrong way of measuring the center edge angle. This is the correct center edge angle. All that is posterolateral. And if you look at the CT, it will give you a more exact center edge angle. Or the MRA. So this is an MRA, and I just took two cuts. The bottom one is the anterior cut. So this is the proper center edge angle, which is a normal one. So the patient does not have the classic increased CE angle. And I took the same angle, put it on the posterior cuts, and you can see that there's an exaggeration in the posterior cuts. So it's a posterolateral overcoverage, not a lateral overcoverage with a classic increase in CE angle. So these are the findings that we're looking at, and this is the new thing I've been seeing, is an indentation of the head on the posterolateral part. So when you extend, you pull the traction of the head, you find these indentations on the posterolateral part, and you find fraying of the labrum very posterior. We're talking here about 10 o'clock position. So 10 o'clock, beneath 10. So 10 to 12, you find the fraying of the labrum, you find indentation of the head. Okay, and associated with that, the classic anterior labral tear is there. It's not different. So this is the video, just showing you once we went inside. This is the posterolateral labrum. A lot of the time it's associated, is ossified, and I think Sada will speak about that. There's an ossification of the labrum, so there's no malleability. There's bone behind the labrum causing this impingement. And this is the head. And look inside here, you can see the indentation of the head. Once you do, we're in flexion position. Once you do abduction, you can see where the labrum and the head are impinging. They're both, you can see there's indentation inside the head. It's not a cam. The cam is outside, but you can see it only either in the flexion position or when you do the traction and you get the head out, then you see this indentation. You don't see it in the normal position. So you start by decompressing. We need to decompress the labrum, this ossification. So we detach the labrum with the radiofrequency, with the burring, and all this extra bone from the lateral from 1 o'clock all the way down to 10 o'clock should be removed. And this is, again, once we've done the traction, then this part, this indentation, you can see now that it's a very clear indentation. It's not the cam. We've removed part of the cam, but it's posterolateral indentation. And you can see where it's fraying and impinging on the posterolateral labrum. So if you see a labral injury down at 10 o'clock, think of this posterolateral impingement. Again, you have to stress on acetabular-plasty posterolateral, so we don't only remove the classic acetabular-plasty, usually doing it from 12 to 2 o'clock, maybe a little bit at 3 o'clock. This is from 12 downwards to 10 o'clock, all the way down around the curve to decompress the labrum. We do then the classic labral repair. Once you've decompressed, the labrum can go back. So in the initial view, you've seen it in a certain area. It goes back once you decompress the acetabulum, and then you finish your cam, and you do the classic labral repair. So here you're considering your anchors. You will have an anchor around 11 o'clock, and your repair will be 10 and 11 o'clock, plus the usual anterior repair. In this case, we needed also some fine-tuning for the cam. So the arthroscopic findings is a prominent posterolateral acetabular rim, ossified labrum, you may see that, posterior head indentation. As I said, you may find the classic anterior labral tear in the front, the reverse contre-coup, and commonly, and one of the telltale signs beside the indentation is the fraying of the labrum and ossification of the posterolateral part. The arthroscopy, we do the classic peripheral axis first, as I was taught by Michael. Capsulotomy, the cam osteoplasty. You do your posterolateral acetabular-plasty, again stressing that you need to go down from 12 all the way to 10 o'clock, and your labral repair also will be extended downwards posterior. So the literature, I didn't find much talking about that. This was described in 2017 by Dome, the reverse contre-coup lesion. They have described it, but they describe it in a different scenario of anterior capsular laxity, excessive anteversion. So they're describing, I think, slightly different pathology. But this posterior head indentation, I personally, I think it's new, at least to me in my experience, and I'd like to hear the experience of the other experts with us here. If you look, this is just another case. So they've got classic anterior labral tear, delamination. You can see that this is 12 o'clock, but after pulling the head, you can see the indentation in the head again. And this is the video again. You see, this is after pulling during traction. We've done our repair. We've done an anchor here at around 11, and still you have your all the way down posterior labral fraying, and you can see the indentation at the head. The cam is distal to that. The indentation is more proximal. You only see it once you do the traction. Beside our, on the left side, this is usual pincer decompression 1 to 2 o'clock. This is the posterolateral pincer decompression, and at the bottom you see this is how it looks after, and this is the more anterior pincer. So you're going all the way around posterolateral. Again, this is just showing you even after our repair, you can see how much the fraying. You can see 12 o'clock all the way the fraying is going down, all the way down 10 o'clock, even sometimes 9. That's your posterolateral impingement. So just in summary, to remind you to keep an eye for this posterolateral impingement, acetabular overcoverage, labral fraying is the telltale sign, head indentation, look for that, and you may find the reverse contra-coup lesion on the front and you need to repair it. The treatment is similar what you're doing on the fung, but it's in the posterior part, which is posterolateral acetabular plasty plus labral repair. Thank you.